So there are several options open to us. No, and what decision we need to take is very critical. So this course would deal with that. We know the order, but because Dr. Sirisha is leaving, she's got a flight in the evening, we're going to little bit reverse the order, have the last talk first. Role of the minimally invasive glaucoma surgery in doing a cataract and glaucoma together.
Thank you for shifting the talk. So we know that with the number of glaucoma medications that we have, the number of surgeries itself have come down. So 90% of our glaucoma patients are basically treated medically, and those that require surgery desperately need a pressure control that's that the medications cannot really bring down. So although trabeculectomy has been there for almost half a century or more, it's still the gold standard, and we have only modifications as we go by, whether it is the antifibrotic agents or some other modifications with the surgery itself. One of the major issues with having surgery with a bleb is that we have innumerable complications, especially with the extensive use of mitomycin if it is not appropriately applied, and whether the dose and the duration is not adequately used in different indications. Over a long period of time, if these eyes are there with blebs, they can end up having complications like this. So when we are looking for alternatives, there have to be two reasons why we are looking at alternatives. One is it has to be safer or it has to be effective. There are only two reasons why we have to look for an alternative. Something you have is very good. For example, you have a phacoemulsification which is very good. It's quite safe and effective. I don't think we are looking for alternatives. We are only trying to see if we can better it. But here in trabeculectomy, we are trying to look at alternatives because of the fact that we can end up sometimes having unsafe surgeries and problems related to bleb and hypotony. So there's an increasing demand for safer surgery, and that has brought to the minimally invasive glaucoma surgeries, where there is a huge number of surgeries that are coming up with different types of implants, and a lot of money has been put in the R&D with these devices. Basically, they are non-penetrating, no bleb surgeries, and essentially no hypotony. So the safety is the primary concern. Efficacy, outright, they accept that they bring about moderate IOP control, but generally have a safety profile. So depending on the types of implants that we have, we can broadly classify them into three types. One is the ones where we try and use the Schlemm's canal with a natural passage. The second one is you use the suprachoroidal space for better drainage or alternative drainage. And the third one is the subconjunctival. These are the list of MIGs that are available, and in fact now if you look at it, there are more and more that are already added up to these. So looking at the trends of glaucoma surgery in the US, number of trabeculectomies have been significantly going down, and number of these drainage devices, that is the MIGs, is only increasing as time goes by. And most of these devices are actually designed to be used along with phacoemulsification. So phaco alone lowers the intraocular pressure, that we know that it sometimes can also be sustained over a long period of time. So what they are doing now is something called as phaco plus. That means you do a cataract surgery and add a MIGS along with it. So of the available technologies that we have, most of them are using the opening up of the trabecular meshwork or the Schlemm's canal. What we have is the trabectome, where it uses a high-frequency electrocautery to ablate the trabecular meshwork and open up the Schlemm's canal to the anterior chamber. And there is another procedure called as ab interno examer laser trabeculotomy, and that also is using the same kind of technology, where it's a different technology but same mechanism, where you cause micro perforations of the trabecular meshwork and trying to let the fluid drain from the anterior chamber into the Schlemm's canal, and from there onwards it is the natural pathway. There is a most popularly used stent, which is the eye stent, which is from glucose. You have these eye stents are basically, again, devices that can be inserted into the Schlemm's canal. The idea is most of the open-angle glaucomas have the obstruction or the resistance at the level of the trabecular meshwork. So you're using something that will bypass that obstruction and reach the Schlemm's canal. Once it reaches the Schlemm's canal, the fluid is going to go through the collector channels, and it has its own external pathway. So there are, this is how inside the eye, the opening of the eye stent looks like. And one of the important considerations while using these eye stents is that we all assume that Schlemm's canal is otherwise open and the collector channels are draining things well. So if you just bypass the trabecular meshwork, you think that you will be able to reach the Schlemm's canal and the fluid will drain, but there are issues with that because you can have segmental collapse of the Schlemm's canal. You can have part of the Schlemm's canal that is not formed itself. So that is something that we need to look at. And so if you look at, when you enter the anterior chamber and induce a little bit of hypotony, in some areas you will be able to see this blood in the Schlemm's canal. That gives you an indication as to where the collector channel could be, and you can plan your eye stent insertion somewhere closer to this. And nowadays people are using more than one eye stent to say that suppose they've used one in an area where the collector channel is not there, then possibly the fluid is not going to filter very well. So they use multiple eye stents at least 2 clock hours away. So these are some of the results which have shown the more number of stents you use, the better the IOP control as time goes by. One more device that is available is the Hydrus implant, which is an 8 millimeter long, slightly elastic implant, which is made of a material called nitinol, which is also flexible. The back part of it is open and the front actually contains 3 to 4 openings. So this is again inserted into the Schlemm's canal, so it occupies about 2 to 3 clock hours of the area of the Schlemm's canal, and one part of it is open into the anterior chamber. So the fluid is supposed to go through this. The reason why you have such a large implant is that it's supposed to not just let the fluid reach the Schlemm's canal and go through the collector channels, but it's also supposed to open up the Schlemm's canal and keep it patent. Histopathological studies have shown that this is quite compatible with the human body and it does not induce any inflammatory reactions. Another group of stents that are available are the suprachoroidal stents. So what this actually does is basically based on the understanding that we have, PG analogs work much better than any other anti-glaucoma medications topically that we have. That is because it uses an unconventional uveoscleral outflow pathway. And it also has a negative pressure gradient that drives the fluid in that direction. And we all know that post-trauma, when you develop a cyclodialysis cleft, it induces hypotony. So letting the fluid, directing the fluid into the suprachoroidal space, and that will get drained away from there is one concept that all of us know. So using this, they have come up with multiple shunts that are available. One such available stent is the CyPass micro stent, which is a very tiny micro stent. So it usually is inserted between the iris and the end of the angle. So a part of it is open into the angle, the rest of it sits in the over the ciliary body area. And this also brings about a good intraocular pressure control. There's something called as eye stent supra, which again is a modified eye stent, which is used not to go into the Schlemm's canal, but a part of it is opening into the suprachoroidal space. Although when you say viscocanalostomy or modifications of viscocanalostomy are actually not mixed because you try and open up the conjunctiva there, but there are modifications that are available which are also there to open up these Schlemm's canal and try to use canal expanders to keep the canal patent. The other group of implants that are available are the subconjunctival devices, where you go through the angle of the anterior chamber. That means you don't open up the conjunctiva, but go through the angle of the anterior chamber and use malleable, soft implants to be placed in the subconjunctival space. These are so soft that they conform with the shape of the eye, and this again does not form a large bleb, but very diffuse, low-lying bleb is something that can be achieved. So these are some of the results that have been published, where what they actually look at is not the amount of intraocular pressure control. Even if you have a 20% or even lesser intraocular pressure control, they're not really worried about. But what they actually are looking at is how many anti-glaucoma medications can we try and reduce. So same thing, preoperative and postoperative intraocular pressure control is, yes, there is a difference, but not a significant difference as compared to the number of anti-glaucoma medications. There's another concept called as mix plus. That means whatever implants that you already have, you try and see if you can try and increase the efficacy. Because until now, we said that it is basically trying to bring down moderate amount of intraocular pressure control. They're quite safe, but their efficacy is not very good. So they're also trying to modify these implants that are available as well as the surgical techniques to see that can you increase the efficacy by also keeping the safety margin. So what is available is Zen implant with MMC, CyPass with Visco, to try and enlarge the space or the lake around the implant, plus eye stent supra. This is how, just an example or a picture to show you if this is how CyPass stent is passed, the little bit of lake that you form around and that much of fluid can reach there. On the other hand, if you inject viscoelastic on either sides, it tries to enlarge the lake so that the amount of fluid that drains is also more. So there are studies which from ICAF's group which show that when you do CyPass Plus with visco, it tries to bring down the intraocular pressure control a little bit more than just the CyPass. So these are these various devices that are available to us, and some of them go through the Schlemm's canal, some of them into the suprachoroidal space, some of them into the subtenon or subconjunctival space. So now let's come to this, is MIGS better? And if you ask this question, compared to what? None of these studies have actually compared them with trabeculectomy, which is our conventional surgery, but all are compared to phaco only or compared to the number of drops that they're using in the preoperative period. And I don't think they are trying to cover that up. They're very clear about it, that it's not a replacement for TRAP. It's just an adjunctive to cataract procedure. If somebody does not want to use medications or on too many drugs or has even those patients where they are non-compliant, they are not using their drugs properly, you can try and reduce the medications. But remember, all this can be done only in those patients with open-angle glaucoma. The ones that have angle closure, the kind of advanced glaucomas that we see, where you want really low intraocular pressure control, I don't think these are some things that are very useful, and that's one of the reasons why many of us are not doing it in our country. But what we need to remember is something that is new, and it also definitely shows a great promise. It can provide drop-free IOP control with less surgical risk, but for how much intraocular pressure control, how long can this work, and the cost benefit. They are all very, very expensive. I don't think we can, at this point in time, afford it, at least until the newer modifications come up and they tell us that, yes, it's worth using that implant because the cost effectiveness is something that we can look out. I think we can use them, but we need to use them very judiciously. Like I said, they are not indicated in advanced glaucomas or when you have a progression or when there is uncontrolled intraocular pressure and when you need a lower target intraocular pressure or somebody who's intolerant to medications, because none of these patients will be totally off medications. Yes, some of them may be, but most of them may require medications. So if you have a drug allergy, again, be careful whether you have to use your MIGS or not. Like I said, again, although the topic is MIGS, I just want to reiterate the fact that they're not bad. The new ones are not necessarily need to be better than what we already have. So at this point in time, unless we have something revolutionary that comes up, I think we still should hope to do a trabeculectomy and combine it with ATO cataract surgery or whatever to bring down lower intraocular pressures. But be careful with doing your surgeries, selecting your cases, as well as doing a meticulous surgery to prevent complications. Thank you.
Thank you. Anybody has got any quick questions before we have a keynote speaker, Dr. Victor Kova, who is in a teaching institute in Philippines. He's going to talk about managing angle closure glaucoma from research to clinical practice. Any questions for Dr. Sirisha? Sirisha very nicely highlighted what are the options at this point of time and where does it stand now in the globe. Some of them I'm sure may be available in the future for us, like how we have Bavel tube now in India, but we have to look into the cost effectiveness part, which is very important. Are these going to be cost effective? No, if it's going to do a magic solution, yes. And more importantly, we should keep in mind all this is for open angle glaucoma. Still, majority of our glaucomas are angle closure. Again, trabeculectomy or even cataract surgery would be a gold standard. So practice intraoperative gonioscopy and be ready to do some of these procedures as cataract surgeons. Many cataract surgeons are now getting into glaucoma in US because of the availability of MIGS, doing an eye stent or an ab interno canaloplasty. So once we can see gonioscopy during cataract surgery, many of these procedures can become comfortable. So if you have a Swan Jacob lens, start practicing it. Victor is ready? Welcome.
Good afternoon. Thank you very much to the organizers for inviting me, and congratulations for a well-attended conference. I'm Dr. Kovar. I'm from the Philippines, and I will not claim to know a lot more of angle closure compared to the number of population that you must probably see here. But I do a bit of angle closure surgeries in the Philippines. So this is my disclosure. The WHO ranks glaucoma as the leading cause of irreversible blindness. At present, there are 20 million with PACG globally. By 2040, 34 million will be affected, 5.3 million will go blind. In a paper published in 2014, giving a glaucoma projections and glaucoma burden through 2040, they showed with 50 prevalent studies all over the world, 24 of which are from Asia. They showed that the overall global prevalence of glaucoma is around 3.54%. The global prevalence of POAG is 3.05%, and the global prevalence of PACG is 0.5%. The highest prevalence of glaucoma in POAG is in Africa, and not surprisingly, the highest prevalence of PACG is here in Asia. In areas like Mongolia, China, and Myanmar, PACG is actually higher than POAG. And if we segregate Asia into East Asia, South Asia, and Southeast Asia, you will see that East Asia and Southeast Asia will have higher prevalence rates compared to the global prevalence, with 1.1, 0.96, and even here in South Asia, we'll have a prevalence rate of 0.66, a little bit higher than that of the 0.5. So I am a bit of an epidemiologist also. So based on the prevalence rate of 3.02 in South Asia, out of the approximately 1.38 billion India aged 40 to 80, which will be around 31.5%, 434.7 million by the year 2020. It's estimated that there will be around 13.12 million people with POAG and PACG. And the number of people with POAG will have 10.3 million, and the number of people with PACG around 2.9 million cases. So we go to a typical case. We have a 56-year-old female with blurring of vision in the right eye, complained of for the past few months of intermittent headache, not consulting anyone, self-medicating with oral medications. Just a few weeks later, before consult, complaining of blurring of vision and eye pain, eventually seeing you in your clinic. Past medical history, non-smoker, non-diabetic, you're a run-of-the-mill PACG patient. On consult, sees you with the right eye counting finger vision, left eye 618 improving to 660, hyperopic patient with elevated IOP on the right eye. On gonioscopy, on slit lamp examination, you would see the right eye here before treatment, and after controlling, after a few days, it settles down with clearer corneas, but of course with still mid-dilated pupils and atrophic iris. So on gonioscopy, you would see on the right eye, the angles are really closed, even on indentation, and but on the left eye, there are areas wherein the angles open up a bit. So after the cornea cleared up, you were able to do some disc photos and visual field tests, which showed some cupping of the disc on the right with some note of visual field defect. So in a patient who you've treated with laser iridotomy and or iridoplasty, would you do, and with uncontrolled pressures, would you do a trabeculectomy, a phacotrabeculectomy, phacoemulsification with IOL, or a phacogoniosynoculisis? So let me go through this. Of course, the treatment of choice in patients with ACG is still laser iridotomy, plus or minus iridoplasty. So the purpose of this is to relieve the pupillary block created by full thickness hole of sufficient diameter. So these are the indications, and we've known this for textbook. So this is a UBM image of the cornea, iris, and the lens. The picture on the left showing the forward convex iris configuration prior to iridotomy, and the picture on the right shows that the iris appears to be closely opposed to the lens centrally, and its periphery takes on a flatter shape. In a study published in Singapore, in Asian population with APAC, prophylactic laser iridotomy is safe and effective in preventing acute angle closure in fellow eyes. In addition, prophylactic iridotomy prevents long-term rise in IOP in 88% of fellow eyes. However, there is a proportion of patients wherein there is an increase in IOP. Thus, these patients really need to be followed up. So the argument against just doing LPI in patients with acute primary angle closure is growing. In a paper published in 2008 in Hong Kong, they compared lens extraction to LPI alone. So among the APAC eyes which received early lens extraction, only 3.2% had IOPs greater than 21 millimeters mercury, compared to 46.7 eyes after an LPI was performed. Of course, the number of medications was significantly fewer in the lens extraction group compared to the iridotomy group. So their conclusion was early lens extraction after initial control of IOP and symptoms could be a very effective treatment in APAC. So let me go through the options that I listed out earlier. Trabeculectomy has been the gold standard in medically uncontrolled glaucoma, regardless of angle status. However, TRABs are associated with various potential serious intraoperative and postoperative complications, especially in PACG. We see and hear about horror stories of hypotony, choroidal detachment, maculopathy, cataract progression, and of course, bleb-related complications. So, Salmon had a retrospective study examining the outcomes of trabeculectomy and advanced medically uncontrolled PACG. So he was one of the earliest people who published results on trabeculectomy in primary angle closure glaucoma. So the IOP was successfully reduced in less than 21 millimeters mercury in 66.7% of patients, compared to 24.4% with topical glaucoma medication. However, he noted that trabeculectomy was effective and relatively safe in managing advanced chronic angle closure glaucoma. However, a third of their patients required secondary procedure, either a secondary trabeculectomy or a cataract surgery within 3 years. Comparing trabeculectomy to phacotrabeculectomy, Chai had a paper published comparing the long-term results of combined TRAB with cataract extraction alone. So 75 of them received combined surgery and 24 had trabeculectomy alone. So the results showed that a 3-year complete success rate was 56% in the combined group and 54% in the trabeculate group alone. So patients in the combined group did not require any additional IOP lowering procedures, while 54% of eyes in the trabeculectomy group required either cataract extraction or IOP lowering procedures. So with the two big studies, it showed that TRABs in PACG could not be the gold standard that we had hoped that it would show. So lens extraction alone, as we all know, deepens anterior chamber, it widens the drainage angle, it reverses the anatomical predisposing factors of angle closure. We all know that PACG eyes have thicker lens, they have steeper anterior capsule surface, and more often anteriorly positioned. So Wishart and Atkinson was the first to suggest LE alone as initial procedures for eyes with cataract and PACG. At the time, they were still doing ECCEs, so what he did was he compared patients with PACG and open-angle glaucoma, and then he looked at the results. So among the PACG eye, there was a lower incidence of acute postoperative IOP elevations, and most of them achieved IOP less than 21. Naturally, in the open-angle group, the IOP control was mainly unaffected. So Lay et al. Also had a small research wherein he had 21 patients, and in patients with PACG and cataract extraction alone showed significant reduction in IOP and required far less glaucoma medications. Of course, the results were controversial at the time because no big published clinical data showed good evidence for it. Up until the 2016 EAGLE study came out. This is a multi-center international randomized controlled trial which determined if the clear lens extraction was superior to laser peripheral iridotomy plus topical medical treatment. So in this study, clear lens extraction showed greater efficacy and was more cost-effective than laser peripheral iridotomy alone, and should be considered as an option for first-line treatment. So clear lens extraction versus TRAB showed that clear lens extraction can reduce mean IOP by 34% and reduce mean number of drugs by 60%, whereas TRAB reduced IOP by 36%. So TRAB actually did better than clear lens extraction. However, the TRAB group had 45.8% more surgical complications compared to the clear lens extraction group, which showed just 3.8%. Foregoing that, we go to the phaco-GSL. Phaco-GSL is a lot cheaper than doing all those MIGs, and it requires no other equipment except maybe a lens and a spatula or something to press onto your iris. This technique was first described by Schaefer in 1957, consisting of intraoperative identification of anterior synechia using gonioscopic lenses. I prefer using the Swan-Jacob lens to visualize the angle structure. This procedure can be performed on the nasal side, the temporal side, and with much difficulty on the superior side, superior angle. This procedure can be used with a lens, the Swan-Jacob lens, which is preferable, compared to performing it without the lens, with just pressing onto the angle, which can cause cyclodialysis clefts, hyphema, a lot of iris disinsertion. And this procedure had a multi-center medical records review done in 2013, which showed that there was success in 61 to 86% at 3 years follow-up. So this is a short video using a spatula, opening up the angles and visualizing up to the sclerospheral and ciliary body band. So the whitish part that you see at the bottom is actually not the sclerosphere, but it's actually the atrophic iris which was attached to the peripheral cornea. So you see the thick iris atrophic area at the bottom, and then above that you actually see the scleral spur. So we have had a lot of success doing this in patients with PACG. In fact, I have not performed a trabeculectomy in any of my patients that I've had to do a GSL on. So Tang reported a retrospective study comparing the effectiveness of phacoemulsification and viscogoniosynoculitis, wherein they showed when they compared the trabeculectomy, and their results showed that GSL resulted in lower requirement for glucomatous medications, a greater improvement in best-corrected visual acuity, and higher cumulative probability that treatment would be successful among patients with PACG and coexisting cataract. Robert Rich and his group in New York also published a paper on this, wherein he had 81 patients who had PACG and with angle closure of more than 6 hours. And his results showed that up to around 91% of his patients had reduced IOP of less than 21. Comparing GSL to trabeculectomy, you will note that the GSL patients may have post-IOP spikes, may have radiodialysis, but you see none of the horror stories that you can see, such as flat anterior chamber, hypotony, malignant glaucoma, bleb-related problems, or late endophthalmitis that can happen in trabeculectomies. So, postoperatively, the phaco-GSL may have some corneal edema, will be technically harder to perform because of the edematous cornea in the shallow chamber. but it may be something worthwhile and very cost-effective in patients with PACG. This is my second to the last slide showing a possible algorithm that you may follow in patients with PACG. So in patients wherein patients may have cataract or without cataract, performing phacoemulsification alone in medical control, or phacoemulsification alone in patients with medically uncontrolled may be preferred. And without cataract, based on the EAGLE study, doing phacoemulsification alone may be helpful in such situations. So going back to my question, after the presentation, would you do a trabeculectomy, phacotrabeculectomy, phaco with IOL or phaco-GSL? Well, like I said, I do the GSL 100% of the time, of course, except in UVT cases.
Excellent.
So this is written also in the Asia Pacific Glaucoma Guidelines, and thank you very much for your invitation.
Thank you, Kovar. No, for highlighting the point that there is a real less expensive option available. I'm sure cataract surgeons, if they can do a good gonioscopy, again they can do a comfortable GSL, right?
Yes.
Thank you again. So now we have Dr. Sood, who's got a tremendous experience in managing glaucoma. I selected him for this talk because whatever be the cataract, he'll not touch the cataract, right, Sood? So he's a man who does glaucoma surgery alone. So he'll talk why trab alone if he gives an option for a procedure.
Instruction course, whatever may be your intention. So basically, cataract and glaucoma, when they are present together, are a challenge to the ophthalmologist. And the challenge is twofold. One, as a part of the decision-making process, should you go in for a cataract surgery alone? Should a glaucoma surgery be done first, followed by a cataract surgery? Or can the cataract and glaucoma surgery be done together? The second part is to implement the decision that we have taken so that the patient continues to maintain his vision if it doesn't get better, and the optic nerve function should not get compromised. So let's look at it from the cataract point of view, and the type of cataract we're dealing with is very important when you're going a part of the decision-making process, particularly when you're looking at a posterior capsular cataract. You've got to be extra careful because of the vigorous scraping, vacuuming of the calcified opacity, which could result in a capsular tear. Then when you have a pseudo-exfoliation, because from a cataract surgeon's point of view, the endothelial cell count will be reduced, the polymegathism and pleomorphism would maybe require you to use a better viscoelastic. And then you'll also find that eyes with pseudo-exfoliation tend to dilate less, and the capsular tear can happen, and the zonules are very, very fragile, and therefore a zonular dialysis can happen. When you have a posterior synecdoche formation, there's a possibility of post-operative inflammation happening, and there can be a rise in intraocular pressure. And if you're manipulating for a poor pupillary dilatation, then the dilatation, that entire manipulation could further worsen the process, and it's always good to be careful in these patients. From a glaucoma point of view, you must know the kind of glaucoma you're dealing with. So if it's an angle closure you're looking at, it's good to do a laser PI first. Shallow anterior chambers as a part of your clinical examination. Remember that a pre-op trial with dilatation does not rule out a pupillary block on the day of surgery, and gonioscopy needs to be done, and patients with shallow chambers may need to be treated prophylactically just to ensure that something like this doesn't happen. Developmental glaucomas, these are patients where you may not look at cataract surgery as a first choice. And then again, pseudo-exfoliation from a glaucoma perspective, the zonules will be weak. They're more likely to be more post-op inflammation, and there could be a rise in intraocular pressure. And eyes with pseudo-exfoliation are more prone to vitreous loss during surgery. If you're dealing with trauma, then the cataract seems very enticing, but remember there could be an intumescence of the lens. There could be a subluxation or a dislocation of the lens. The angle outflow structures could show a change, and you got to build this up into your decision-making process. These eyes are prone to inflammation. And again, when you're looking at inflammation, they're posterior synecdoche, you could deal with them on the table, But the more you deal with them on the table, there's likely to be a post-operative fibrin reaction and a rise in intraocular pressure that you would need to deal with. The second thing you look at from a glaucoma perspective is what is the severity of the glaucoma you're looking at. So perhaps here a cup-disc ratio of 0.6 up to 0.6 is suggestive of a minimal optic damage. 0.7 to 0.8 could be a moderate, and 0.9 and above is actually indicative of a severe optic damage. In case you can't visualize the optic disc, you could depend on visual fields. Remember that when you look at the total deviation plot, there'll be a marked depression, and the focal depression, which is seen on the pattern deviation plot, may be exaggerated, but this would give you an idea of the generalized depression that you're looking at. And again, fields can give you an idea whether you're looking at an early glaucoma, a moderate glaucoma, or an advanced glaucoma. You could look at the 10-2 or a 12 degree if you're using the octopus, and this could help provide you with clues to fixation characteristics. So if you see this here, you find that there is marked crowding in the central 5 degrees and fixation is spared. Similarly, here you could assess crowding in the central 5 degrees and fixation is split. Two things which have revolutionized the management of cataract and coexisting cataract and glaucoma is the presence of medication, particularly prostaglandin analogs. The advantage here is that they can effectively reduce intraocular pressure and their systemic side effects are minimal. They've also helped simplify the dosage schedules, ensuring better patient compliance. And these, combined with other drugs, have helped to change our approach to coexisting cataract and glaucoma. The second thing is the transition from ECC to scleral phaco to clear corneal temporal phaco. That has helped us to preserve conjunctiva for a future surgery, and because surgery is done in a relatively watertight eye, it's easier to get better pressure control and make sure that we can get good results in the long run. So clear corneal phaco is the preferred method for cataract surgery in patients with moderate glaucoma. So when would I do a glaucoma surgery first? So it's always the glaucoma which is dominating the clinical picture. The glaucoma surgery would be to lower the intraocular pressure independent of the cataract. The second thing I would keep in mind is the severity of the glaucoma. So if I'm dealing with a glaucoma which is severe or advanced, fixation is involved, or there's crowding in the central 5 degrees on a 10-2 or a 12 degree program, then I would opt for a glaucoma surgery first. And fields would help me decide whether whether fixation is involved. So this would actually, the severity of the glaucoma would be more valid when you're looking at advanced patients with primary open angle glaucoma or a chronic angle closure where the laser iridotomy has been done. It also depends on secondary glaucoma. So when you're dealing with a secondary glaucoma, various types of secondary glaucomas, because they tend to be more refractory in nature, you would like to do a glaucoma surgery first and as a first choice. More so in patients who have a neovascular glaucoma or developmental glaucoma. You can see an action field rigors are normally here. Uveitic glaucomas, because they tend to respond differently to any surgery. And then when you have an uncontrolled uveitis which is active, you'll actually find that you have to operate for high intraocular pressures. These eyes can respond differently. The other thing to keep in mind is the stability of the glaucoma. Traditionally, we have depended on structural and functional assessment of the optic disc to see whether the glaucoma is progressing or not. I'll just show you an example of one of our patients. This is an eye syndrome, same eye, 2007. You just see the eye here, and then in 2011 and 2015 you find this, and it's progressing. So what I would actually like to do here is do a glaucoma surgery first and not combine it with a cataract surgery at any point of time. This is again another patient with eye syndrome in 1998, and you find that the atrophic changes are progressing here in eye syndrome. We took this patient up for a glaucoma surgery first and then followed it up with a cataract surgery. So here's the summary. You would opt for in a situation where you're dealing with a coexisting cataract and glaucoma, you would go ahead with a glaucoma surgery first when you find that the glaucoma dominates the clinical picture, is perhaps not stable. The severity of the glaucoma is going to make you opt for a glaucoma surgery first and follow it up with a cataract surgery if you require. Then it's the type of glaucoma. The primary advanced glaucomas would definitely need glaucoma surgery first. Secondary glaucomas, usually you'd like to go in for a glaucoma surgery first because they tend to be more refractory in nature. A glaucoma which is progressing should ideally be treated with a glaucoma surgery first. And also if you find that the number of medications is 3 or more, it might, to get control of intraocular pressure, then it might be safer to plan for a glaucoma surgery first. And I acknowledge the support of my colleagues in making this presentation. Thank you very much.
Thank you, Sood. Any quick questions to Dr. Sood? Yes. So I think Sood very nicely highlighted where you would do a trabeculectomy alone, so that the eye becomes more quieter and softer for the cataract surgeons to comfortably deal with the cataract. Some of the times it's very critical. Before Kovar started his talk, I would have chosen trabeculectomy alone. Then we chose phaco with gonio synoviculitis. But basically, even in an acute angle, post-acute angle closure attack, it will be nice to do something like a trabeculectomy, make the eye softer, and then take them up for cataract surgery. That's what our usual practice is also. So now, Ganesh, even though it's a little bit of overlapping with what Kovar had covered, but still Ganesh would highlight some of the few areas where he would do cataract surgery alone.
Thank you, sir. I'm standing in for Dr. Tanuj Dada, who's not here today. Thank you, Dr. Venkatesh and Chairman Scientific Committee for providing me this opportunity to speak to you here when I do cataract surgery alone. And now we have some plethora of evidence that cataract surgery has the potential to reduce intraocular pressure, and the precise mechanisms and biometric changes that influence the reduction in IOP are actually undetermined. So if you see certain studies, you have a significant reduction of intraocular pressure at 1 and 2 years' time, and the only anatomic factor on A scan associated with such study was the lens thickness. Other studies also have shown significant proportion of intraocular pressure reduction, especially compared to preoperative IOP, and they are not affected by age. And phaco versus eye stent, we have seen some studies by Samuelson et al. They reduce the intraocular pressure by more than 20%. So these are all related to open angle, whereas if you compare with the narrow angle group, you have a less significant reduction of intraocular pressure. Narrow angle groups perform better, especially when you do phacoemulsification alone for these patients. And also decrease in intraocular pressure at 6 months was more in the narrow angle group compared to the open angle group. And you have a lot of studies which show that open angle eyes, pseudoexfoliation, chronic angle closure, they have reduction in the number of medications required for treatment after surgery, that is cataract surgery alone. And a lot of theories also exist, especially the release of prostaglandins, why the IOP reduces the release of prostaglandins. Angle opens up, the trabecular meshworks release cytokines which have better percolation through the trabecular meshwork. And corneal hysteresis also can play a significant role as a mechanism for IOP drop. So if you were to compare phacoemulsification, the cumulative dissipated energy, it has no role as far as the proportion of IOP lowering efficacy. So there is no correlation between the amount of CD released inside the eye and the IOP lowering effect. Dr. Venkatesh's study, as in 2015 published in ophthalmology, has nicely illustrated the role of manual small incision surgery versus phacoemulsification, the intraocular pressure drop. You find that both of the surgeries reduce intraocular pressure satisfactorily. So you find that the intraocular pressure in both the groups reduce significantly at 1 month and 3 months. And also you have greater IOP lowering with patients who have higher preoperative baseline IOPs in both the groups. And this is something similar to a lot of other studies which have also been published. You have a greater drop in patients who have higher baseline intraocular pressure. And also when you talk about angle closure, you have early lens extraction, trabeculectomy, combined trab, and goniosynoviculitis, as Dr. Kava has presented. So the important thing is here is to look for the relative lens vault, which is significant in angle closure disease, and patients who have higher lens vault have a much better reduction of intraocular pressure following cataract surgery alone. And this is another study which is comparing the laser iridotomy with phacoemulsification in patients who had acute angle closure. And 18 patients had LPI and 19 patients had phacoemulsification. And they perform it, and the phacoemulsification with IO will result in lower rate of intraocular pressure failure at 2 years compared to laser iridotomy alone. That's understandable mainly because it's a angle closure disease, is a progressive phenomena, and then with the cataract gone, naturally the results should be a little better. And the Eagle study compared LPI versus early lens extraction, and this has already been alluded to. I'll just show you one particular issue. It's the intraocular pressure drop was only 1.18 millimeters lower after the clear lens extraction than the standard care. That's really significant considering the gravity of the situation and the ongoing process of angle closure disease and the amount of IOP fluctuation that can occur. So although it says that greater efficacy is there in clear lens extraction, I think at face value we should look at it little with more detail. Certain other studies have also compared phacoemulsification with trabeclectomy, and significant reduction in synechial closure and increase in anterior chamber angle width was obtained in these eyes. And you have others by the THAM group, which compared phacoemulsification with trab with MMC, and they also concluded that trabeclectomy is more effective than phacoemulsification, reducing dependence on glaucoma medication, but is associated with more complications. So these are certain things which we should understand when we manage angle closure disease. And you also have, when you compare phacoemulsification alone with combined phacotrab, you have the phacotrab group is more effective than phacoemulsification alone in controlling IOP. But on the corollary, it is more commonly associated with post-operative complications. So goniosynovitis has been dealt in very much detail. I won't go into that detail again. So in conclusion, IOP does drop following cataract surgery, and IOP will drop even in glaucomatous as well as non-glaucomatous eyes. So whether you do a manual small incision or phacoemulsification, you can be rest assured that the intraocular pressure drops. And the amount of energy used also does not have any role. So where would you like to do cataract surgery alone in a patient with open angle, for example, when you know that the patient knows that there may be a later requirement for a glaucoma surgery? Such are the patients who you can offer for, and in the complex situation of glaucoma as well as cataract, you have to assess, like Dr. Sood has already pointed out, which component is playing a more significant role for the patient. So if it is cataract, you can do cataract surgery first, provided the patient understands that, because glaucoma is an age-related disease. In cataract, many patients will occur 10 years ahead of time compared to advanced glaucoma stages. In angle closure disease, what do we do? When the intraocular pressure is above normal, we try to reduce it by topical or systemic IOP lowering medications. We always consider doing a laser iridotomy first, mainly because it prevents post-operative chances of malignant glaucoma. And when you have acute angle closure, these are not suitable for immediate laser iridotomy. We can always do argon laser iridoplasty. We also do surgical PI for such patients, which help in reducing the intraocular pressure. And after laser iridotomy, prostaglandins have been shown to better control intraocular pressure. Lens extraction may be tried in certain situations in eyes which are medically controlled with medication. Only one thing you have to understand: once you have a acute angle closure glaucoma attack, the glaucoma attack doesn't really repeat itself. So we have seen many patients in whom we have taken off the medication, but of course we monitor them closely, whether we do cataract surgery or just follow them up. So this is a flow chart which shows, so you have uncontrolled chronic angle closure, you have cataract present. Usually I would prefer to do a combined phacoemulsification, and you can always have the option of goniosynovitis. We also do significant amount of phacotrabeclectomy in such eyes, mainly because patients would be benefited from a single procedure. But if you have uncontrolled glaucoma, If the cataract is not there, then trabeculectomy alone is sufficient. More effective than phacoemulsification reducing, depends on glaucoma does. But if the patient is on multiple medications and the cataract is the one which is more disabling the patient, then we would definitely think of doing a cataract surgery alone, especially in certain situations like a monocular patient. Thank you very much.
Thank you, Dr. Ganesh. Our next speaker is Dr. Venkatesh, who's going to talk to us about managing difficult situations like small eye, crowded iris, and weak zonules.
Okay. When we have decided to do a cataract, I think we tend to face a lot of issues as glaucoma surgeons. I mean, most of the complex cataracts the glaucoma surgeons tend to do because of these issues which happens related to shallow and the very deep chamber when you're operating. So your situation arises like this, when do you see? So mainly shallow chambers have crowded iris also because the anterior segment is basically crowded. So these are some of the conditions where we commonly encounter cataracts which are either intumescent or maybe with glaucoma also in it, the phacomorphic component. The phacolytic is very easy to deal. The phacomorphic components are notorious for problems, and then eyes with microphthalmia, eyes with significant narrow angles. Either they may have synechia or not, but still we have to deal with them very carefully. The other condition which is normally misdiagnosed or not diagnosed properly is plateau iris because it's very difficult to diagnose. And then the other important condition to keep in mind as glaucoma surgeons is nanophthalmos. So keep in mind anything below 21 or 20.5, these are nanophthalmic eyes. You have to be very, very careful in these eyes because they are notorious for having surgical complications. So it's so important that we need to do a very good preoperative assessment, a very careful anterior segment examination. There will be a subtle iridotomy which we can miss, or there may be multiple iridotomies which can have zonular issues during surgery. So sometimes the patient may not remember an iridotomy at all. So when we have to sometimes search for some of these iridotomies. Definitely, I think gonioscopy is very important when you're going to decide surgery on some of these patients. And again, biometry is also equally important. In these small and long eyes, axial length measurement errors can translate to a greater errors in your IOL power calculation. So you have to use the best formulas so that you don't miss, and even if you have the best gadgets, you use that. An IOL master or an immersion biometry is ideal for eyes which are smaller and bigger. Again, if you have an access to these tools, it will be good to do, like what Ganesh was saying, to understand the lens vault sometimes. The higher the lens vault, there is more risk for them to go for closure. You can even go for an early cataract surgery in these patients. And UBM to understand conditions like plateau iris. And of course, the role of specular microscopy is also important when we are operating on cases with eye syndrome and other cases where you need to really protect the endothelium. But whatever be the case, we have to make sure you protect the endothelium very well in shallow chambers. All this have to be kept ready in your OR. I don't want to insist these points, especially a good high molecular weight viscoelastic, which could make your rexis much more comfortable. So you're dealing with eyes with iridotomies and previously weak zonules and pseudoexfoliation. So you need to keep capsule tension ring and also segments ready, and also vitrectomy because you may land up with complications. So deepening the chamber, ideally some of these patients you have to, when you prepare them, it will be good to give nice, make the eye really soft by giving intravenous mannitol and also digital massage to some extent, and use high molecular weight viscoelastic and try techniques like soft shells technique, which can really deepen the chamber so that you have a very good control on in the anterior chamber and also in performing the capsular exis comfortably. When you're doing a phaco, I think these are some of the points to ponder and keep in mind. A very good incision is very important. The leaky incision, again, already a chamber is shallow, can still worsen your condition. And when you're doing with a normal machine, you have to raise the bottle height to increase the infusion pressure into the anterior chamber. And decrease the outflow by kind of lowering the flow rate, and use modes which will be comfortable in the form of pulse or burst modes, or use a torsional phaco if it's available, so that less energy is delivered, because the chamber is so shallow. Even if you are in the bag, some of the pieces can come into the supracapsular area and can then damage the endothelium. So try to be in the bag, but try to do a kind of slow motion phaco where you have all reduced parameters working with you. So ideally, it will be good to do techniques which are in the bag, especially phaco chop technique if you are good enough, or you can do a stop and chop if you are not mastered a phaco chop. Trench nicely, deeply, and then separate into two halves, and then try to multiply make as far as possible, make these pieces really small enough so that they can be emulsified right in the pupillar area, so that they don't come into the anterior chamber. So see, there are some of the very important points to keep in mind, and when you're dealing with cases like this, nanophthalmos, it will be nice to do procedures which would make your surgery safer. I think sclerectomy, some of the surgeons routinely do. Some people do a closed vitrectomy and make the eye softer, remove a little bit of vitreous. Some people even perform a blind vitreous tap, which is again debatable, but as far as possible, when you are doing eyes which have axial length less than 20.5, 21, we need to be really very careful. And as I said, some of these eyes will have iridotomies already, multiple iridotomy, weak zonules, so that also has to be kept in mind. You have to keep all this ready, whatever way you want to expand the pupil. But some of these cases, ideally, you have to use iris hooks, which can really make your rexus bigger and have a very good control on your rexus. And the nucleus, mostly, if you try to do it early, it may be easy to do. But sometimes some of these lenses may be really hard. So you need to deal with the energy level at a higher stage, but ideally you can keep it under your control by doing a torsional method, so that your energy is saved, so that your endothelium is also safe in some of these eyes. So you need to make sure you have your bottle height, like what I was describing in the previous case. So here I'm trying to keep a pressure of 50, but ideally you can increase the pressure, but I'm worried about the glaucoma part also. So you can raise the pressure or the bottle height so that you can have a good infusion into the eye, but basically try to do everything inside the capsular bag like how I'm doing, and then making it into really small pieces so that you emulsify. And in harder cataracts, whatever technique you're comfortable, you can do a double trench, and then even you can go deeper and fracture the nucleus into smaller pieces. And as you see here, whatever we do, the back space is so less, it would tend to come. So in between, it's nice to come out every time and inject a good amount of viscoelastic between the nucleus removal, so that you can keep on coating the endothelium and keep it much more safer. So dealing with the vitreous, as I said, in some of the eyes, like in phacomorphic and very narrow angles, or sometimes intraoperatively also, you can have a situation wherein the eye becomes very hard. It's not going for an expulsive, but the eye is becoming hard because of the dehydration into the vitreous. So some of these cases, you can do a vitreous tap. So there are, as I said, some people just use needle to aspirate, or you can do I saw a nice technique where they just put the sclerotomy and then allow some amount of vitreous to get out, or you can do an automated vitrectomy, a controlled vitrectomy, or even a pars plana vitrectomy if you have already planned to do one, which would deal with the vitreous and make your eyes softer for you. So this is what I normally do in phacomorphic glaucomas. I prefer small incision, of course, over phaco. Ideally a good big incision, and this is how we do a vitreous tap, using a 23 gauge needle. You go through pars plana, you aspirate 0.2 ml of vitreous. Sometimes even without a plunger, it will come out. Passively it will come out. If it comes, it's okay. Otherwise, you may have to aspirate it. And once you do that, you have a nice space in the anterior chamber. And then you enter the eye. Before that, it's not a good idea. Then rest of the procedures, it becomes much more comfortable. So the other eyes, the myopes eyes and the deeper chambers, which are again more common in glaucoma, I'll just share with you a small tip which is described again. No, when you have a very deep chamber, it's very difficult. No, you have to keep your microscope zoomed down, and then you'll have to focus. So that's a small tip. Now, if you just lift the iris, you break the pupillary block, the reverse pupillary block there, and the chamber becomes normal. Sometimes you can have a little bit of meiosis, but you will have an ideal chamber, where you can comfortably do a phaco. So this is a small tip. Using your second instrument, Yasinski hook, you have to just raise the iris at some point. So where gently raise like that, and that breaks the reverse pupillary block, and the fluid flow under the iris to equalize between the anterior and posterior chamber, and you will have a normal anterior chamber to do with. So this small tip you keep in mind. And this is just a nice video we made to just show you what happens at different intraocular pressures. Some of our patients are compromised nerves, and people even with compromised optic nerves, when the pressure goes up to 30, you see what happens to the vessels. There is marked constriction of vessels. And when it goes to 45, you can see how these vessels get constricted. So the more the pressure in the eye, all this can happen in your machine, which you're not. So this is done in a vitrectomy. I mean, the Constellation machine, this recording was done. When it comes back to 10 millimeters, you can see how nicely the blood is flowing in the vessel. So keep this in mind. So the perfusion of the optic nerve head is important during procedure. So somewhere, I no commercial interest, but the active fluidics which Alcon offers gives a very good control on the intraocular pressure. So some of the glaucoma patients now I try to reduce the pressure to a greater level, as low as it was introduced. This topic was introduced by my good friend, again, Shariat, you all know from the Shariat tunnel. He says the low infusion pressure micro-incision cataract surgery, basically you can keep as low as 30 or even 25, and you have a very good control in the chamber. You can do all the steps very comfortably, chopping or emulsifying the nucleus. Little bit of surge I felt coming down, so I keep at 30 in some of my glaucoma patients. I don't come below that, but this particular recording you can see at 26. You have a nice, good chamber, well-formed chamber, and most of the steps you can comfortably do without much of a surge or collapse in the eye, because the fluid infusion is so low here, and you have a very good control on what you're doing. So these are some of the points which I thought I would insist when you're doing cataract surgery in some of the glaucoma patients, but it's so important that we need to do a very thorough preoperative evaluation, and then make your eye really soft when you're taking them up for cataract surgery, and keep everything ready on your table so that you have backup to deal with some of the issues which narrow angles have. And finally, it's so important that post-operatively also you have to meticulously follow them up. It's not like your regular cataract. They may have post-operative pressure rise, so you may have to see them day 1 or 1 week or 10 days, a couple of weeks later, so that you can manage the inflammation when you're using iris hooks and things like that, and also to control the intraocular pressure, which could compromise on the nerves. Thank you again.
I'm going to talk on combined surgery, that's manual small incision cataract surgery with trabeculectomy. Now, first we have to understand why we should do a combined surgery. Smith and Sivalingam first described this combined surgery for glaucoma and cataract. It is basically one surgery may succeed in both clearing up the central vision loss from cataract and in controlling peripheral vision loss from glaucoma by lowering the IOP. So possibility of worsening cataract following glaucoma surgery alone is eliminated, and after glaucoma surgery, the subsequent cataract surgery may induce inflammation and cause glaucoma surgery to lose its effectiveness or even fail. So IOP control is usually better after a combined procedure. Now, combined surgery provides an early visual rehabilitation of the patient with cataract and glaucoma, reduces the risk of early severe post-operative pressure elevation, may provide long-term reduction of IOP, and decrease the need for glaucoma medications. Glaucoma patients mostly remain undiagnosed because of relative lack of detailed disc examination and also lack of awareness. Now, coming to the main topic, why manual small incision cataract surgery and combined surgery? It is an acceptable option to treat patients with cataract and glaucoma. Manual small incision cataract surgery offers many advantages. It has a wider applicability, it has a better safety, it has a shorter learning curve, shorter duration taken for the surgery, lower cost and high efficacy without the use of sophisticated instruments like the phaco machine. Complex cases like rock cut cataracts, lens-induced glaucoma, pseudoexfoliation, subluxated lens, small pupil, corneal opacities can be better managed with manual small incision cataract surgery. So what are the indications? Cataract with glaucoma patients, basically failure to achieve target pressures by medications, issues related to compliance and adherence to medical therapy, borderline controlled IOPs, disease progression or near maximal medical therapy, and advanced glaucomatous damage, and along with other types of cataracts which I already mentioned before. So coming to a small video on a combined surgery. Basically, we have to be very careful when you take the superior rectus. We should take the superior rectus in one go. We should not damage the conjunctival tissue. Always measure. In minor small incision cataract surgery, I take a 6.5 millimeter marking on the conjunctival marking. You mark the conjunctiva with the help of a caliper stained with the trypan blue. Then in one go, try to separate the conjunctival tissue, conjunctiva and the episclera. You know that near the limbus there is an attachment of the conjunctiva and the episclera close. So in one go, cut it, separate it, dissect it, subconjunctival dissection throughout in the posteriorly and towards the lateral side so that we have a diffuse bleb. Use gentle cautery, never over cauterize, just identify the bleeders and cauterize it, otherwise you have shrinkage of the scleral flap. Again, mark it 6.5 millimeter on either side of the limbus and about 3.5 millimeters from the center of the limbus behind. I make a triangular flap. Always make sure that you cut in one go. Don't make multiple cuts, and hold the tip of the scleral flap and try to separate it with a 15 number blade. You should not have multiple tiny this thing. You should try to make it as smooth. The scleral bed should be as smooth as possible. Always you can use a sponge or a cotton bud to avoid the bleeders, and you can tell your assistant to always pour the saline so that bleeding gets arrested and you don't have to recauterize all the time. Never try to use the cautery on the perforating vessels which you sometimes encounter on the scleral bed. Try to use pressure with the cotton bud and try to stop these bleeders. Enter about 1 millimeter inside the clear cornea. Then with the help of a crescent blade, try to make a tunnel. The most important thing when you're doing a minor small incision cataract surgery is the lateral two pockets. These are very important because this gives you a valve effect and gives us a better control. So you can see this is the type of lateral pockets made. We are not going to touch the conjunctiva at any time throughout the procedure. Try to hold with the scleral flap because scleral flap has a good intensity. It gives a good stability. Make the side port, and now you are going to follow all the steps which you do in a manual small incision cataract surgery. So the only difference what you did here was the construction of the scleral flap and the separation of the conjunctival tissue, and without damaging the conjunctiva, you have to make this procedure of the combined surgery. Rest, you enter the antechamber with the help of a keratome. Always make a dimple, then go parallel to the iris and then make the keratome so that you get a good valve. So once the entry is made, as I told you, it's basically a manual small incision cataract surgery procedure. Make a rexus depending upon the size of the IOL which you are going to put and the type of cataract. Usually in SICs we advocate a larger rexus because we want to prolapse the nucleus out and dilate out into the antechamber. A small rexus is not advocated unless and until the cataract is soft and you want to put a 5.5 millimeter optic IOL, then you can do it. Throughout the procedure, you have to be careful. Whenever you have any bleeding at any point, try to flush it. You don't want him to be present over there. Now, inject viscoelastic below the cataract and above the iris and the posterior capsule and take out with the help of irrigating vectis. Now, when you do that, you have to use the rectus. So, what I would suggest is the rectus, the superior rectus in the suture, what you take is very important. It should not damage the conjunctiva at all. So, you can see that the whole cataract, with the help of a side port and the main tunnel, we have aspirated the whole cortex and taken out the cataract. Now, I am injecting the IOL. When you are injecting the IOL, always try to put the IOL into the bag and always try to place the fabric on either side. You should not place it superiorly or inferiorly. Now this is the main other step which we are going to do, that is a trap. I use a 15 number blade or a punch depending on the need. You first mark the 2 by 1 millimeter, you mark it by fine scratches with the help of 11 number blade, and then once you have marked it, you cut it. So you get a nice rectangle, and always do a broad-based iridectomy. You can put a releasable suture or an intermittent suture. It's your choice how you want to do it. I usually do one intermittent suture at the apex and then 2 releasable sutures on either side. Always be careful when you're putting this suture, inject air bubble so that the AC is always maintained and you don't have shallowing of the antechamber, because frequent shallowing of the antechamber will give prostaglandin release will be there, and that will again lead to failure of your bleb. So an intermittent suture is taken, then a releasable suture on either side is taken. I'll show you the technique of the releasable suture. You take a clear bite into the clear cornea parallel to the limbus. Once you take this bite, then you come perpendicular to the limbus from the clear cornea towards the scleral bed. Once you have taken this bite, then from the scleral flap to the intact sclera, you have to take this another one. So basically, it is 3 throw, parallel to the limbus, perpendicular to the limbus, and from the scleral flap to the scleral bed to the intact sclera. Then take 4 throws. These throws should not get entangled because this is very important when you're putting a releasable suture. It's basically a slip knot. So make sure your throws don't get entangled. You take nicely 4 throws and then with the help of the loop, tighten it. You can have a tight, the basic advantage of this releasable suture is you can tighten the suture as much as you want so that you have a formed entry chamber, and you can titrate the IOP post-operatively by releasing the suture one by one, or even sometimes we can just release a bit and then trim the suture. So this is the way we are going to put the releasable suture. I'm putting a releasable suture on the other side also. So now when you're putting the second releasable suture or when you're putting the third suture, you always you have to make sure that you wash the visco. So before you close it, I'm washing the visco, trying to separate if there's any, even though we have done a broad-based iridectomy, sometimes this iris tissue can get blocked towards the internal ostium. So by washing the visco and trying to separate the iris away from the internal ostium, and then under the air bubble, I put the other releasable suture, and then once it is done, we can do the hydrodissection so that the AC is maintained, and then I'm putting the conjunctival 80 Vicula suture. Conjunctival suture is always an intermittent locking suture, so that we get a tight two anchoring sutures at the limbus. We don't want any leak, and try to avoid any perforation or any trauma to the conjunctiva. You don't want any buttonholes into the conjunctiva, so you have to be careful. Usually you can take 2 or 3 sutures based on your preferred technique. I usually take 2 or 3, depends on the type of conjunctiva I'm dealing with. So you have to put a tight sutures at either end. This should be very tight, and you should create a perfect apposition near the limbus. If there is any leak, then you have to take the sutures at the center of the conjunctival flap also. So once it is done, you do a hydrodissection, try to see the patency of the bleb. Now you can see that the fluid is coming out into the subconjunctival space, and the bleb is nicely formed. Another thing, now you have to trim the releasable suture. The best way to trim the releasable suture is try to depress the cornea with the help of the vanas and then trim it so that you don't have any exposure and chances of infection is avoided, because you get this suture which is embedded into the clear corneal groove which is made. And always make sure that you give the subconjunctival deca, genta, whatever your preferred thing, into the inferior nasal quadrant so that we have the other part of the subconjunctival space intact. Another way of doing the internal ostium, I'm just showing you a few other ways. I showed you all one with the triangular flap and with the help of a 11 number blade. This is basically a straight flap. This is very easy. The normal SICS, what you do with the straight flap, you make a straight flap, but only thing is you have to try to expose the roof of the tunnel a bit more. And then you can't use the 11 number blade in this type of tunnels. We have to use punch. You can use whatever size available. You use a punch, make a nice internal ostium, and then do the iridectomy. So this, you can see, this was a straight normal SICS tunnel. Just follow the precautions which you have to take for the conjunctiva and other steps of a normal SICS. You follow this straight tunnel. No need to make a triangular flap. And you can put one intermittent suture, and also you can put a releasable suture. In this, one intermittent was put, one releasable was put, and you can see how nicely the bleb is formed. This was. This is another technique wherein if you don't want to use a 11 number blade, you can do also with an MVR. Once the triangular flap is made, you use the MVR, just enter into the blue-white junction, go straight inside, and then you can use Vana scissor, or with the MVR itself, you can just cut the 2 horns and make a nice this thing. So I entered with the MVR, made the single cut, and with the help of Vanas, I'm cutting, and this is internal ostium which was created. And this is another variation. And one thing which I would like to say is, whenever you're making a spiral flap in the beginning, if you have a buttonhole, you have to abort the surgery and make the surgery shift to another side. And if you think you're going deeper, that the UL tissue is getting exposed, try to change the plane and start on another plane at the same level. Don't panic that, I've gone deeper and the UL tissue will go on prolapsing. Just be delicate. If you increase your magnification and have a look, there is a tissue covering it, so you won't have any problem. So combined surgery, that is manual small incision plus trap, is useful for IOP reduction and visual improvement, a formed entry chamber, central replaced IOL, and it gives a filtering sclerostomy in the absence of ocular hypertony and inflammation. Thank you.
Thank you, Dr. Amit Porwal, for demonstrating various techniques of manual small incision trap. Now I request Dr. Deepak to present his talk on combined surgery, single versus twin site. Dr. Deepak is Chief Medical Officer of Aravind Eye Hospital in the Dindigul branch in Tamil Nadu. Over to you, Dr. Deepak.
Thank you, sir. Thank you for your nice words. Now we are very much clear that when to do the combined surgery. So the topic allotted to be the managing cataract and glaucoma combined surgery single versus two inside phacoemulsification with trap. So by this time, we are very much clear that when to do the cataract first or trap first or combined surgery, either SICS or phaco. So I will be just talking regarding phaco trabeculectomy. There are two ways we can deal with this situation. Either we can do through a one side or we can do by the two sides. So first, what is single site phacotrabeculectomy? As the name suggests, both the trabeculectomy and cataract surgery is dealt at the single site, means at the 12 o'clock position. So here the surgeon is sitting at the 12 o'clock position, and the trabeculectomy and the cataract surgery phaco is performed using the same conjunctival and the scleral incision. This is small picture which shows that, is it clear? Yeah. We can see that at 12 o'clock position, we have triangular flap is there, and from the same site, we will do a scleral corneal tunnel and perform the phacoemulsification. So this is single site phacotrabeculectomy. It's a small video. After performing all the fornix-based conjunctival flap, square scleral flap is being fashioned. We can use both the crescent knife or 15-degree blade knife. I'm using the crescent knife. Always expose the area with the silk suture and make the area very much clear. Now once you are in the clear cornea, 1 millimeter, you make further using the crescent knife and enter into the anterior chamber. Though the pupil is small, okay, as regularly we don't give all the classical cases. Some are small glaucoma, is diseased eyes, some have a small pupils, some have posterior synechiae, all those things. So this is a small pupil. We try to just dilate with the ordinary intracameral and perform a capsulorhexis, 4.5 millimeter capsulorhexis, and do the hydrodissection as a routine. What we do perform in the phacoemulsification, make the anterior chamber always fill up with the viscoelastic devices, and check before doing surgery, proceeding phacoemulsification, whether it is rotating or not. These are the simple principles we always follow during the phacoemulsification. The first chop comes, then we try to, since the pupil is small, we will try to make as many small pieces, and so that we can perform the in-the-back phacoemulsification. So once you see that the phacoemulsification is completed, the phaco tip is always in contact, or the IA tip is always in contact with the subscleral bed, and the conjunctiva at the same time is being always rubbed by the phaco tip or the IA tip. After the completion of this cortex was, then this foldable intraocular lens is implanted into the bag. The scleral tunnel is usually little larger when we do through a single site, so it may be little difficult to insert the IOL into the bag. So after performing, we do using a punching. So almost 2 millimeter block we will make to the blue, and after that, this PI is iridotomy is being performed, and you can check whether it is clear or not. You can put both the releasable as well as fixed sutures. We put most of the times fixed at the apical and 1 or 2 releasable suture. Check for the bleb function, and AC should be well formed. So what is the advantage? Advantage over the two-side is that only single wound is made. Certain condition where cornea scarring is there, temporal pterygium is there, we can't do temporal surgery. So in those situations, the particular situation, it is better we can go through the single site phacotrabeculectomy. And at the same time, in the OR room, you need not to change your position. The sister need not to change the position, microscope, everything. So this is the advantage. At the same time, we see the disadvantage of single site. During surgery, we have noticed there are lots of manipulation at the scleral bed of the conjunctiva. So the excessive manipulation of the conjunctiva and subscleral manipulation may influence the outcome of the filtration surgery. More manipulation, more inflammation, more fibrosis, and it will affect the result of the filtration surgery. So, and at the same time, when you are using some antimetabolites, then we should take care that there is no leakage, means everything should be thoroughly washed out before performing the phacoemulsification. So now the next what we do routinely or classically to inside phacotrabeculectomy. There the temporal clear corneal incision is given, and the phacoemulsification is performed that one. So surgeon moves after performing the temporal clear corneal phacoemulsification. Surgeon moves towards superiorly and perform the trabeculectomy. So its technical ease in the cataract extraction. We all know that doing phaco surgery through temporally, we have a wider glow, good view, all those things. So it's very easy, and our surgery, our complication rates are also very less when we do temporal surgery. So at the same time, when you are doing temporally, then you are not touching the subscleral flap tissue or conjunctiva tissue with your phaco tip or IA tip. So there is a minimal manipulation at the trabeculectomy site. So you can see in the diagram that at temporally there is a corneal incision for phacoemulsification and superior or superior-nasally. First superior-nasally, we try to make superior-nasally. In superior-nasally, we have planned for trabeculectomy. The small video. After making a scleral corneal tunnel, this tunnel will be this tunnel is converted into a flap by giving the two side cuts, and this two side cuts are being given. Just we should be very meticulous that it should not be very much deep, and it should over the flap area, so that we can give a very neat square shaped flap. So we can see that flap is now the bed of this flap is very smooth, and now the surgeon we are shifting towards temporally. The sister shifting that side, we are shifting this side, and all those things. Now the clear corneal incision given. Now it is a routine phacoemulsification. While performing the phacoemulsification, we will never touch the conjunctiva superiorly. We will never touch the conjunctiva subscleral tissue superiorly. So that area is totally untouched while doing the phacoemulsification, which has a benefit over the longer period of time when there is filtration is better. So it's a normal phacoemulsification is being performed, and IOL is being implanted into the bag. And once the IOL is into the bag and some corneal edema we can notice here. So always better to secure whenever we are in doubt, always better, especially in the combined surgery, it is always better to put a suture and bury it very well, so that it is easy to manipulate in the POD1 with the finger, so that we can make some filtration function by digital function. So the surgeon has shifted, we have shifted to the now superiorly, and after AC entry into the clear cornea, punching, and that is now the same. After punching, then irectomy and checking the patency, and place the two fixed sutures and with tendon nylon, and the conjunctival flap too is sutured with a vicryl suture, airtight, watertight suturing, and we see the pattern. So we have seen both the single site and twin site surgery process. What is the advantage? So once we see that improved exposure of the cataract section through as I discussed, we are all doing most of our phaco surgery temporarily, so we have a good exposure, especially in the eyes where the deep seated eyes, where brow prominence, narrow palpebral aperture, or in the shallow eye, where a more anterior entry temporarily reduces the chances of pieces to come up. At the same time, the inflammation is less because there is less manipulation at the trabeculectomy side. So it will enhance the bleph survival, and the visual recovery is also better because we are giving incision at the 90-degree apart. So whatever the astigmatism caused by one incision is neutralized by the other incision. At the same time, disadvantage we look at may be longer. We are shifting from one position to another position like that only. Not much disadvantage. So if we see the efficiency in terms of IOP control, both the approaches have been shown to be effective. Various studies shown both the approaches are equally good and shown to be effective in lowering the intraocular pressure. But the two site may have better post-operative IOP control, and the two site surgery may have less need for adjunctive glaucoma medications. Visual outcome, best corrected visual acuity in the both groups are comparable. Both are equally good, and the post-operative induced astigmatism is lesser in the twin side because we are giving two incisions 90-degree apart, so they are neutralizing the astigmatism caused by each other. At the same time, the post-operative complication and post-operative medication in the both groups are similar. There is no difference. I would like to put one study, the one-sided versus two-side phacotrabeculotomy, a prospective randomized study published in the Clinical Interventions in the Aging August 2015, a recent study by Marita et al. In which the purpose was to compare the efficacy and safety of one-side, two-side combined phaco trap with foldable postage IOL. So 34 patients with 41 eyes with glaucoma cataract randomly assigned to two groups, one side and two side. So result was that it was followed up for 54 months, and the pre-operative mean intraocular pressure was in one side group was 21.3 mmHg, and in two side group it was 21.8 mmHg. And post-operatively, in the one side it was 15.6 mmHg, and two side group it was 14.9. The difference is not very much. One side group required significantly more adjunctive anti-glaucoma medication than the two-side group over a longer period of time. And the base character visual acuity improved similarly in the both groups, and the astigmatism induced was lesser in the two-side groups. And intra-post-op complications were comparable in the both groups. That means there is no much difference between the complication in both the groups. So to conclude, both the technique, single and twin, yields similar results concerning final visual, base character visual outcome and intraocular pressure reduction. The two-side has lesser induced astigmatism and the better post-operative APIC control with less required post-operative anti-glaucoma medication as compared to one-side group. Thank you.
Thank you.
I will like to thank my chief, Dr. George sir, who has given me the opportunity. Thank you.
Thank you. Thank you, Deepak. We appreciate that. So any questions to end the session? We had a very focused audience till the end, but thank you again for being through this session, and I think the general body meeting is starting shortly.